So now we come on to question number 176, and question number 176 was, which of the following characteristics is not true for X-linked inheritance? And the correct answer to this question is option number C, that is carrier woman has 50% risk of having an affected son. So we see that how a X-linked inheritance works. So if there is a carrier woman, how would it go? So this is a carrier woman and this is a normal male. This is a X-linked disease that we are talking about. So we know we see that there is a 25% risk of the male getting affected and 25% risk that there would be one carrier. So basically they were asking you about what is not true for X-linked inheritance. So the carrier woman having 50% risk of having an affected son is the correct answer to this question. So you see here, if you see the option number D, the carrier woman has 25% risk of a carrier daughter. So we see that this is the 25% risk of a carrier daughter. And there is a 50% chance for a child that does not inherit the mutated X-linked gene. So 50% of children have not inherited the affected gene. And males are more commonly and more severely affected than females. That holds true for X-linked inheritance. So, and also that the affected males will only have carrier daughters. They will not have no chance of having an affected son. So option number C is the correct answer. So next we come on to question number 177. And question number 177 was, which of the following is not true for autosomal dominant inheritance? And the correct answer is option number C, that is finding of male to female transmission confirms the diagnosis. So in case of autosomal inheritance, autosomal dominant inheritance, it is a vertical transmission that occurs. So there is a vertical transmission occurring from the parent to the child pattern in multiple generations. So this is one of the characteristics of autosomal dominant disorder. So the transmission is vertical from parent to child. So affected individual has a 50% chance of passing on the gene in the next generation. And how this happens? See by this example. So you have a patient with the autosomal dominant disease. So this is the defective allele, and you have a normal allele. So the combinations would be so you see that there is a 50% chance of passing the gene to the next generation. So the unaffected individuals or the family members do not pass the disorder to their children. So we see that this set, which does not have any abnormal genes, they will not be passing on this disease to the next generation. So basically it is transmission from a male to a male that confirms that it is a autosomal dominant disorder. So vertical transmission can also be seen X-linked traits, but since a father passes on his Y chromosome to the sons, so male to male transmission does not occur in case of X-linked disorders. So here the answer was option number C. So next we come on to question number 178. And question number 178 was, the CSF findings in tubercular meningitis include, and the correct answer is option number B, that is low sugar, high protein and lymphocytosis. So low sugar plus high protein plus lymphocytosis. So this is what a LP picture in case of tubercular meningitis will look like. So in TBM, the onset is usually insidious. Usually the clinical features are divided into 3 stages, stage 1, stage 2 and stage 3. In stage 1, the child may just complain of fever and some headache, while in stage 3, he may have progressed to even coma and may have multiple cranial nerve palsies. Usually, you can also find an evidence of tuberculosis at some other site, for example, the lungs. A lumbar puncture may be diagnostic, which will show low sugar, high proteins and lymphocytosis. If you do a CT scan of a patient with tubercular meningitis, you can find basal exudates, you can find hydrocephalus, that is increased intracranial pressure, and you may also find tuberculomas. So these are the characteristic imaging findings in case of tubercular meningitis. And treatment involves administration of anti-tubercular drugs along with steroids and decongestive measures to decrease the intracranial pressure if there is evidence of raised ICT. So next we come on to question number 179. So question number 179 was, true for bochardelic hernia is, and the correct answer is option number B, that is congenital hernia. So as was mentioned, bochardelic hernia is usually posterior in origin and not anterior as it was given in one of the choices. It basically results due to the failure of the fusion of the pleuroperitoneal membrane between the 8th to the 10th week of gestation, and majority of cases occur on the left side. And affected newborns will have respiratory distress since birth. It will not begin later in life. So next we come on to question number 180, and question number 180 was, in what maintenance dose can vitamin D be administered in breastfed full-term infants? And the correct answer is option number B, that is 400 IU. So it has been found that the breast milk is deficient in vitamin D, and these days vitamin D deficiency is very rampant. So all neonates up till 1 year of age, it is recommended that they may be supplemented with vitamin D in a dose of 400 IU. So next we come on to question number 181, and question number 181 was, which of the following is a neural tube defect? And the correct answer is option number D, that is all of these: spina bifida, encephalocele and dermal sinus, all these are neural tube defects. So option number D, all of them are neural tube defects. So basically neural tube defects result due to failure of closure of of the neural tube between the 3rd and the 4th week of intrauterine life, and neural tube defects like meningocele, meningomyelocele, dermal sinus, encephalocele, anencephaly. All these are examples of neural tube defects, and administration of folic acid can prevent the occurrence of neural tube defects. So next we come on to question number 182, and question number 182 is, which of the following cyanotic congenital heart disease is associated with least risk of heart failure? And the correct answer is option number A, tetralogy of Fallot. So we know, and we had discussed previously also, that TOF is a condition that's amongst cyanotic congenital heart diseases can have increased pulmonary blood flow or decreased pulmonary blood flow. So basically conditions which have increased pulmonary blood flow like TAP-VC and TGA will have recurrent pneumonias, and they can have CHF as well, while those with decreased pulmonary blood flow like tetralogy of Fallot will present with hypercyanotic attacks or TET spells. So tetralogy of Fallot rarely presents with CHF, but there are two exceptions to this that you should know, and that is presence of anemia and infective endocarditis. So in the presence of these two conditions, even a child with tetralogy of Fallot can present with failure. So you should know both these things. First, that the risk of congestive heart failure is least with tetralogy of Fallot, but at the same time you should also know these two exceptions, that presence of anemia or endocarditis can also cause CHF even if tetralogy of Fallot is present. So next we come on to question number 183, and question number 183 was, a 10-year-old child presents with a history of cough and coryza for 3 days, increasing respiratory distress for last 1 day, and whistling sound from the chest since morning. The child has had multiple similar episodes in the past, especially in the change of season. What is the most probable diagnosis? So the correct answer is option number A, and that is bronchial asthma. So we see the clues that we had in this question were, first, that the child was 10-year-old, so he was an older child. Wheezy syndromes are usually common in the younger age group, less than 5 years of age, when even virus infections can also cause wheeze in the chest. But this was an older child, a 10-year-old child. He has history of cough and coryza for 3 days. So possibly a upper respiratory tract infection acted as a trigger, and now has increasing respiratory distress for last 1 day. So there was a preceding URI which exacerbated his symptoms. Then there is increasing respiratory distress for last 1 day. Plus there is a whistling sound in the chest. That means there is a wheeze on examination. And you also got another clue in this question was similar episodes, especially in the change of season. So history of similar episodes in change of season, they point you towards the diagnosis of bronchial asthma. Apart from that, other history that may also suggest bronchial asthma is when there is increasing cough after emotional outbursts. So if a child is laughing or crying and then he has bouts of cough, that will also signify airway hyperreactivity. And also if the child gives a history that the symptoms are more at time of, during the episodes, the symptoms are more at the time of night, that will also point towards the diagnosis of bronchial asthma. And about the rest of the options, bronchiolitis usually occurs up till 2 years of age. It does not occur in a 10-year-old child. In foreign body aspiration, usually the symptoms are of sudden onset. And in this case, you already have a history of preceding URI first, and second, that you get a history of similar episodes in the past. So a foreign body can present with recurrent pneumonias, but it cannot present in such a finding with every change of season there is a VZ episode. While in case of bronchopneumonia, it will be an acute episode, it will be infective. You may not get a history of preceding URI in such a case. So in this case, clearly the answer is option number A, that is bronchial asthma. So next we come on to question number 184, and that was, wide fixed splitting of second heart sound is a feature of, and the correct answer to this is option number A, that is ASD. So wide fixed splitting is characteristically seen in ASD. Next we come on to question number 185, and question number 185 was, all of the following are differential diagnosis of acute flaccid paralysis AFP except, and the correct answer is option number D, that is cerebral palsy. So basically what is AFP or acute flaccid paralysis? Basically, this is one of the most important ways of surveillance which is undertaken as a part of the polio eradication program, and it is defined as any paralytic illness of acute onset in a child less than 15 years of age. So basically when we diagnose a case of acute flaccid paralysis, that is the first thing we have to do is we have to report it to the team, to the surveillance team. They will examine the child, they will take the stool samples to the laboratory, and they will examine if polio virus is found in this sample or not. So basically this is one of the main this is a way of surveillance in the community to see if the polio virus is still circulating. So in this case you see that the options that you had were polio, transverse mellitus and hypokalemia. All the three are differential diagnoses of acute flaccid paralysis. But cerebral palsy, you know, is not an acute condition. So cerebral palsy is the correct answer to this question. So this cerebral palsy is not a differential diagnosis of AF.